So I'm really, really pleased to welcome Niall. Sorry, we've not had a chat, but Niall has literally skipped off the train in Carlisle. He's going to do his presentation, and he's going to skip back on the train again, give or take. So I'll let you. We're really pleased to have you. It's really nice that you've come to talk to all of our first aid providers, and I'll let you introduce yourself now.
Thank you very much. I'm hoping you can hear me okay. Is this microphone working yet? So my name is Niall Elliot. I'm a sports and exercise medicine doctor, so it's a rare breed but increasingly more common breed of doctors. We've crossed Hadrian's Wall, which means that there are more sports and exercise medicine doctors in England. It's not recognised in Scotland, and that's an NHS government issue, so not to worry, we're working on it steadily. What I'm hoping to do, if I can, is talk you through a little bit about what is concussion. You'll be watching rugby at the weekend. We will probably count 2 or 3 concussions in the international matches. You'll have dealt with concussions in terms of the roles that you do. So what I wanted to do is give you an update as to where we are, but also give you a bit of a backstory. This is Ben Robinson. Ben Robinson is a 14-year-old boy, Northern Irish, sustained a concussion. I'll read this because I appreciate the screens are quite small, but Ben took too many blows to the head in too short a space of time. His death could and should have been prevented. For something like this to happen, Peter, his dad, says that there have been so many failings, and on that day, unfortunately for Ben, there were just so many failings. There should have been a chain, and we're used to the chain of survival. There should have been a chain of health and safety procedures in place, one that included players, coaches, referees, parents. If just one link in that chain had worked as it should have done, Ben's concussion would have been spotted, he would have been removed from the pitch, and he may have survived. Really key to be aware of that story. If we go back 10 years this year since Ben passed away, and Ben's parents, Peter and Karen, have been big advocates. Peter now lives in Scotland and the borders. Big advocates are pushing the mantra of just saying recognise concussion, remove them. They don't understand where they're at. And I'll try and go through that a little bit in the 15-20 minutes I have to put that through. What we've learnt over the years is whilst in Scotland we've had a concussion guidance, the suits and boots turned up 10 years ago to sort of promote if in doubt sit them out. We had chief medical officers from the government, chief medical officers from the different sporting organisations, university professors. Okay, that's good. There's a world consensus on how to manage concussion, so we're aware of the science that's changing. In 2018, we thought we'll try and make this a bit more athlete-friendly. Let's put up a few athletes to showcase, get rid of the suits and boots, and try and make sure that we actually put that message out 3 years into this next iteration of the World Concussion Guidance. And then I'm really pleased to say that whilst this has happened in Scotland for the past 10 years, as of last year, April 2023, the UK government went, maybe we should have one unified, if in doubt, sit them out concussion process for all sports at grassroots level. I'm not talking about professional level, this is grassroots. Those of us that plod away on a Saturday morning at a park run, these are the concussion guidances that we'd want you to adhere to. So pleased to see that, and actually what that has meant is that we have actually, as ever, North and South, we've gone in, just retweaked the Scottish guidance to make it the 3rd version coming out next month, just after Easter. And it's very much then looking at community sport. So the journey's been suits and boots, high-level sport. We're now into the piece of actually looking after community sport, because that's actually where we think most concussions are happening. Even more so, we've been able to look at some focused groups, and I'll come back to that in a second or two. But if in doubt, sit them out has now been adopted by Australian grassroots sports within the past 2 months, and in New Zealand. Fantastic movements, and Ben's legacy is that drive behind. We need personal stories to give us a bit of an idea how to push this forward, and you'll be aware of this in the different injuries and illnesses and Lyme's disease issues that we come across on that side. So what I hope within the next 15 minutes is that you understand what is a concussion, so you can actually describe it, that you understand what you should be doing in terms of supporting them, and I'll put up a video, but there are lots of videos out there of what a concussion might look like. Understand what is known as a graduated return to activity in sport. Life continues. We used to talk about return to play or return to sport, but actually we still need to get up in the morning, still need to go to school, go to work, buy our shopping, all these things. So actually return to activity is probably more important than getting back to your physical activity and your sport. And I hope that you can walk out of this room this evening and be an advocate for recognising concussion and actually putting your foot in the door and just saying, no, you're coming off. I'm not having this. We'll get you assessed, we'll get you looked at, and bend stories in the back of your mind saying, that shouldn't happen in 2024. So what is concussion? You'll have an idea, and sometimes when you do small group learning, we get you to split off your little groups, you write it all down, or we'll get a Mentimeter and we'll put you up with all the results up onto the screen. You'll have an idea as to what it is. I think we need to call it as it is. TV commentators saying, he's had a mild ding. He looks a bit sparkled. Different words that you'll have heard about it, actually stop. It's a brain injury. It's not a muck about piece. You wouldn't just talk about that saying, you've just sprained your ankle a wee bit, or open compound fracture of a tibia going, there's a wee crack there. You would generally turn around and call it as it is on that side. So what's really important is to understand that it is a brain injury that is caused from direct blow to a head, which is pretty obvious, but also don't forget that whiplash, that sudden movement that you get, is enough to move that jelly within the four walls of your skull and then cause significant damage on the inside. And as we go through the journey of brain injuries, and we learn this from strokes, we learn this from traumatic brain injuries that we see on the motorways, for example, is that we know there's a huge amount of behind the scenes that happens. So if you genuinely want to get a bit geeky, I'll show you a few pictures on that in a second. But the reality is that there's a disruption. There's a disruption in terms of how the cells start to process, how they pass that message on. If that message is blocked, where does it go? What does that look like on the outside? So if I talked about symptoms that you might have in concussion, typically you might say, well, they staggered all over the place, or they looked blankly at you, or they were knocked out cold. There are so many variations on the theme, and that's just basically evidence of what part of your wiring system has been rejigged. Really, really important to understand that, and to understand actually it may not be the obvious staggering, knocked out, whatever it might be. It might actually be a very over-emotional person, and their carer, their partner, the parent comes up and just says, that's just not Johnny. I've never seen this in him before. And when you unpick it, you suddenly realise that they've had a tumble up the glen, they've done something, and you think, right, actually, I'm not happy with this. So it's not necessarily an overt, easy sign to spot. It may just be a symptom they describe, or something that a carer puts out. And this is bread and butter to us. We should know that as healthcare professionals. I'm hoping the slides will be available for you afterwards. Yeah, good. So there's lots of small writing in some of them, so you can grab them. There'll be links and opportunities for you to go into it. But the reality is at cellular level, there's a shift of calcium and potassium ions, basically blocking down some of the little channels that allow the influx of energy. The use of energy increases significantly. So we know this from intensive care unit where you've had brain surgery or a stroke, is that the energy requirement for a patient in intensive care after a brain injury of some sort is significantly higher compared to maybe other types of injuries. So we have a full knowledge of that. We know that there's increased demand for that. We know that actually the way the muscles get signals from the brain changes, and that will then result in different symptoms. And I've put examples of. It might be they have a slower reaction time. It might be their ability to coordinate has gone completely. It might be that they complain of eye-related issues, photophobia, sensitivity to loud sounds, and migraine. So there's a whole host. So the biochemistry behind it, if what we see on the outside, some clever boffin has put it together and understood actually why that actually happens. It's a mismatch, and what we need to do is protect. I've put players here, but ultimately this could be anyone who sustains a concussion, but we need to protect them. It's really important to understand that. And if we then chuck into the equation to say, but why? I feel fine, I want to go back on the pitch. The evidence is now saying for the first 12 months after your concussion, you are now at higher risk of injuries, other injuries, torn cruciate ligaments, ankle sprains, a variety of upper limb injuries, and the science is stacking behind the scenes. And that's part of the reason why we sort of say, actually, we need you to take this seriously. You need to steadily get back into your sport, because if you don't, you actually might end up with another injury that you had no idea that you could sustain. So again, it's a really important message to put across. What you see, what you have in front of you is subtly different for every patient, and that's really important to recognise. So what I'm going to do is I'm going to play a video. There'll be a bit of commentary. It's BBC, it's from moons ago, but I think it's worthwhile just being aware of it. Vaguely hoping that this is going to work. And I'm going to press play. So I'm jumping ahead a little bit because I'm conscious of time. He's jumping ahead a little bit. The key thing is that you will not necessarily see concussions happen in front of you. There are certain signs that are obvious. They'll be staggering, there'll be loss of consciousness, they might not protect themselves as they hit the ground, which you could see in both those cases. If you're genuinely nerdy over the weekend, use your Sky Rewind, stop and pause it and work your way and just have a look at it. It's really important just to understand what that might look like. It is different for everyone. It might be physical symptoms, it might be mental related issues in terms of, as I said, we talked about sensitivities and sort of anxiety and mood changes that might happen with that patient in front of you. The most immediate reaction is recognising it and taking them off and away from that risk. There are red flags, lots of them, but if I then look at the red flags and think, well, okay, what am I actually genuinely going to be worried about, or the ones that are a bit weird? Now, the typical ones, as you can see, there are neurological deficits, seizures, convulsions, increasing headaches, repeated vomiting, severe neck pain. That should be pretty straightforward. But I've talked about unusual behaviour. I've talked about skull fractures or suspicion of skull fracture. Blood thinning medication, please ask that question. Are you on any medicines? Now, obviously, if they're unconscious, you'll need to talk to someone else about it. And drug and alcohol intoxication always blocks our ability to understand exactly what's happening in front of us. So keep that in mind on top of all the usual red flags. Red flags equals accident and emergency. 999, protect them, look after them, and make sure you remove them safely from that space. If you're worried about a neck, protect the neck. It's, as we all have done with our ATLS and pre-hospital care training, you walk around and grab that neck as you go through. There are some tools out there which have been developed. This is the concussion recognition tool. This is not a diagnostic tool. It's just almost like an aid memoir. You can download it, you could laminate it, you could put it inside any packaging that you have, and again, it's useful. So this is aimed at parents, coaches, non-clinicians, non-healthcare workers, as a little reminder what to look out for. The questions around what day is it, what was the score last week, what we call the Maddox questions, are good, but they don't exclude a concussion. So use them if you want to get a sense check, but if they give you complete rubbish, or if they give you all the right answers, then that's not on its own diagnostic of it. For the first 24 to 48 hours, where we've changed with the guidance is we used to say, don't do anything, rest for 2 weeks, and actually what you did for men and what you did for adults versus children was sort of separated. We've now lumped it together to make it a bit easier. And what we're quite clearly saying is that for the first 2 to 3 days, genuinely take it easy. Yes, go out and go for a little walk if you can tolerate it. Make sure your mild symptoms don't worsen, for example. So headache is the most common symptom that goes on forever. and just allow people to genuinely get back into life. We all are addicted to Facebook and Twitter and all the usual stuff. Please encourage people to take time off their screens, because that stimulus of bright lights and changing lights with their screen will impact on their symptoms, will prolong their recovery. It's been stacked into 6 stages, and again, I won't go through that, but the key things for me are, and I've written it the way out, is that activity and sport go hand in hand. It used to be return to sport and then return to school type thing. Teachers quite rightly have said, no, Johnny has to come into school, but school should know that Johnny had a concussion at the weekend, because he might need to not sit with the iPad, or he might have to go and sit at the back of the class to allow him to read the screen, for example. So teachers need to be upskilled and understand a little bit as to what's happening. But the key bits are that we wouldn't, when asking people not to return to contact sport, as in back to normal rugby training, until they've been 2 weeks free of symptoms, adult or child. Once they've got 2 weeks free of symptoms, then we allow them to get back into a period of full contact training, and then as long as 21 days has passed, that's then back to normal sport beyond that. So it's almost like 2 weeks, 3 weeks has been the 2 headlines, or 14 days, 21 days. And so what I've done is I've tried to sort of show an example of someone who has no symptoms. So they've got 14 days, they've got 7 days of contact training, then they're back to full sport. So that's your 21 days. If you've only 5 days of symptoms, which is not unusual to have 3, 4, 5 days worth of symptoms, 14 days symptom-free, a shorter contact training period, and then as long as 21 days have passed, that's then back into their full contact sport. If you have symptoms for 14 days, and then you do another 14 days of no symptoms, that's going to push you beyond the 21 days. So the reality is they're not going to get back to the sport until they've done at least 28 days away. So 4 weeks, convincing a 17-year-old that he can't play football for 4 weeks is quite tough. But genuinely, the Ben story keeps on coming back up, and I'll explain why we worry about children. And then I'll put another one down to say, actually, if you had symptoms for 28 days, 29 days, that's the red flag of saying you need to go and get seen by a healthcare professional. The 28-day cut-off is when the neurologists want to start to understand what's happening. So it would normally be through the GP. GPs are getting this education at the same time, so they're getting up to speed. But there's an awareness of saying so it shouldn't go on for that length of time, and if it does, please push them in the right direction. 97% of patients within 28 days are symptom-free. So we're talking about small numbers in the grand scheme of things, but just being aware of that sort of 3 to 4 weeks down the line. There are differences, and this is where the research is evolving, in certain groups. So the reason why we've lumped children and adults together is just to make life a bit easier. We've basically extended the adult recovery piece. But children have the risk of second impact syndrome. That's sadly what Ben went through. He had 2 knocks. First knock wasn't recognised, came off, went back on. Second knock, went down, unconscious, never recovered. The second impact syndrome is an increased risk of bleed, and that can be within the first 2 to 3 days of sustaining an injury. So that's why in kids, we genuinely want them off the pitch and to protect them. We don't know if there's a difference between men and women. We think that women report more symptoms. We know that actually in healthcare generally. If you look at the research, women tend to look after themselves a bit better than men and tend to be aware of their bodies and symptoms. So is that the difference? Or genuinely, do women have more symptoms of concussion? We know that women have symptoms that go on for longer compared to men. What we don't know is actually what's the long-term health impact of that. The reality is that the studies are not there. The evidence is not there. It's a male-centric research piece, sadly, and so there's a big shift to try and understand what's happening with women in sport who sustain concussion. So fast forward 5 years, 10 years, we may have a different story. If you're a man, you do this. If you're a woman, you do this for recovery. And disability athletes, again, just take that into mind as to how you're going to move them off that field of play and how you're going to manage them. Visually impaired athletes have prolonged symptoms, take longer to recover. So it's just being aware of who you're looking after, who you're caring for at the end of the day. As a first aider, it is very much making sure that you safely remove them, that you're observing the charge in front of you, that you do become aware of red flags and the change that can happen over a period of time. Make sure that you educate those around you, so the parents, the guardians, whoever's with that individual, make sure that they're up to speed with what you've done. And I would be a real advocate for that graduated return, because If this happens on a Saturday and they're desperately keen to get club training on a Tuesday, at the moment it's a disconnect. We have no way of actually passing that information across. It's coming, but we're not quite there yet. So it's partly your role to say, you need to take this seriously and point them through to where the guidance is, and I'll sort of highlight that at the very end. As a healthcare professional, as a doctor, I have a role exactly the same as any first aid provider. I might have a slightly few more skills in the bag, but not many, to be honest, in the field of play, very much talking to the experts. But it's really making sure that we follow up the patient and make sure we put them into the right space to get the right care, and signpost people. So I've highlighted just a few places. I've also sort of highlighted what the importance is to be a carer or a parent. So that might impact us. I've got a son who plays high-level rugby. What should I be doing? When should I contact the out-of-hours services? I'll put NHS 24, but that's obviously NHS Direct. 111, it's the same number up and down the country. But it's just knowing, and what's good is that NHS 111, NHS 24 have these algorithms built into their questions at the moment. So if you get a call handler and mention the word concussion, they will then start to ask the right questions to highlight red flags, equally give you some guidance around the graduated return to activity and to sport. Final bit is just about the future. I've alluded to it a little bit around some of the special groups that we try and help manage and understand a bit more. You're aware of primary prevention, secondary prevention, tertiary prevention. In this world, primary prevention is trying to obviously avoid them getting the head knocks. So that might be changes in rules in the sport. It might be differences in terms of number of headers that you do. And I know there's a change in football, certainly in Scotland, it's coming in England, where you're only allowed to head on certain days of your training week, for example. So that's going to come. Do head guards make a difference? No, they stop you getting a cut to your head, but they don't actually change what happens to the jelly on the inside. So there's a real debate as to what should be used primary prevention-wise, but there are a few things out there that will help. Gum shields in ice hockey work. Now the research is all in ice hockey. It makes sense to use them in other contact sports. Great for teeth, stopping getting them knocked out. Do they have an impact on concussion? We don't know. The research is purely in teenagers in Canada and ice hockey. We need more data, more information. Optimizing brain health. Sadly, as those of us get a little bit older, don't do as much sport. Thankfully, I shouldn't fall off my bike too often, but I should be eating well, sleeping well, dropping the number of pints I have per day, and making sure that I'm not smoking. So brain health, secondary prevention, and tertiary prevention is very much when you have signs or have a diagnosis. So sadly, as we all get older, we all carry a risk of brain ill health as we get older. And then how do you manage that? So that's the sort of the primary, secondary and tertiary prevention. I've talked about children and talked about second impact syndrome. Talked about obviously women in sport and the knowledge. So this chat 5 years time will be different, guaranteed. Parasport, be aware of it. Long-term health impact, the studies are coming. So there's been some out there linking between professional footballers and their long-term health, and obviously it's high in the press. Is it the heavier balls in the 50s compared to what they are now? No, but actually it was the number of headers. Do we know how much movement was there? There's so many variables in the equation that they're trying to unpick that. There's a few studies suggesting that depending on whether you're a defender, whether you had more chance of ending up with brain health issues in the later life versus whether you're a forward. So that's coming. And it'll be interesting to see whether that means that, don't do any sport and wrap people up. We know that actually being more active is better for you. It is a cancer helper, mood helper, diabetes helper, blood pressure helper. It's the poly pill. It does everything. The measurement of all of this is what we don't know. Not everyone that I see with a concussion will come to see. So flip the way around. Most concussions don't present to healthcare workers. Most of them will be briefly seen by yourself. In a kind way, you record it within your systems, but is that uploaded into the great cloud that sits above us? No. So do we genuinely know the number of concussions that happen week in, week out across the UK? Sadly not, but the technology is coming with QR codes and apps and all these things. So there may be a bit of a push over the next couple of years that you then turn up and go, oh, that's clever, through the NHS app, NHS Inform app in Scotland, but the NHS app where you could actually record a concussion, and then it directs the user through that stepwise process to understand what to do next, the red flags and all the rest. Six Nations is talking about gum shields at the moment and looking at the G-forces that players go. The women have got a G-force set at something like 35 Gs. The men have got a force set at 75 Gs before it pings. There's issues with whether you use Bluetooth technology, whether you use radio frequency technology, whether you use GPS tracking systems. I'm leaving that up to other folk to go through, but this is the first Six Nations that we've had any form of concussion measurement process. Never been trialled at professional game. It's just gone straight in at the top. And for example, some of the stories are that the time it took from one knock to the doctors at the side of the pitch being aware of it was 5 minutes. Okay, it needs more accuracy, it needs to improve. The final bit is education, and I want to show you this picture here because I think this is a brainwave. I've got some fantastic colleagues. I work with Sports Scotland, the national sporting agency. I've got Katie Stewart and I've got Steph Adams sitting on either side there. One's a PhD and basically is an educator around concussion. That's all she's done in life, is learn how to be a concussion educator at university level and at school level. And Katie is a PhD and actually someone who can take small stories and make them into a big one. So basically get it right across sports. This is Moray House, Physical Education Department at the University of Edinburgh. This is the PE degree in Edinburgh. All PE students graduating from the University of Edinburgh now will have gone through 2 mandated concussion and sport modules before they leave. So your PE teachers at school understand what If in Doubt, Sit Them Out is all about. That makes sense, and there's no reason why that shouldn't be extended to other colleagues and awareness on that side. So it's very much a chance to showcase that there's a lot of movement there. It gives you an understanding of what the history is. Very happy to take any questions. At the end, what I've done, I've got 2 other slides that has e-learning modules in and around where you can go and find information. UK Coaching, Scottish Rugby, the Brain Health Scotland course. Don't worry about that, you get your slides. Some of it's through the QR code at the top. But there's also then Rugby Football Union head case. Some of you might have come across that. The English FA have got some brain health websites. And ACORN, which is developed by Greater Glasgow and Clyde NHS, and that's aimed at children. So this is the A&E department in children, and just educating parents about what they should be looking out for, as well as the paediatricians looking after children on that side. So very happy to take any questions. I've tried to compress as much. So yeah.
We are overrunning, but we are going to take questions because Niall isn't going to be staying too long.
Staying until about 2:30, so I'm happy.
Okay, so you're going to be around. Okay, well, let's take a couple of questions and then we need to get to lunch at the back.
Yes, would you advocate the use of 100% oxygen in the initial treatment of somebody that you suspect of having concussion?
Patients are dying for oxygen. It's the way I learnt about it in advanced trauma life support. So if you've got an issue around a cervical spine injury or a head injury, there's increased cellular demand for energy and for oxygen. If you have access to it, there's no contraindication to using the oxygen, I would use it.
Thank you.
Yeah.
Just a thought about when people film 999, not everybody that runs 999 is first day trained.
Yeah.
So I came across an incident, I arrived there 5 minutes after it happened. The story was this guy's fallen off his bike and they asked him, is he breathing? Yes. Is he conscious? Yes. I got there 10 minutes later, he was not conscious. He was sitting on the side of the road, but you say totally vacant, lights are on, nobody's home, totally not with it. But that wasn't the story that they'd given to when they made the 999 phone call. So he was a 4 to 6 hour wait for an ambulance, okay? So I try really on my courses to get across to first aiders the importance. Don't just say yes or no to a is he conscious. You've got to use your aptitude scale to try and explain it. But I just feel there's a lot of people out there who aren't first aid trainers or people who've done first aid courses. There's a need more for the handlers on the 999 call to ask a few more questions, to actually work out the level of where this person is on the scale of are they conscious.
Yeah.
Because the public sees somebody sat up on the edge of on the side of the road as being conscious, when clearly he was not. He was aware of the various. He couldn't speak, he couldn't talk, he was totally concussed. But 4 to 6 hour wait for him was totally not.
It's really difficult, isn't it? Because the mentality from the call handlers will be like a major incident piece. Breathing, not breathing. Not breathing, ignore them. They might have had a heartbeat, there might have been a little bit of a whisper of a breath, but your job in a major incident is just to walk past that person and go to the person who actually has airway, breathing, circulation, and you work your way through. They're doing the same on their call handling sheet. Are they awake? Are they breathing? Are they conscious? And that will then cascade it into the different categories. I appreciate it's difficult, and that's why there's a duty to observe and to support, and just to notice that change over time. It's not easy, and I can't talk, there'll be colleagues here from the ambulance service, I suspect it is really tough for them, given the volume of work that comes through. First aiders, that's why that community concussion recognition tool is really useful, because it just gives you a few little ideas as to what should be a red flag, and therefore, do you know what, and you don't be afraid to phone back. Because, you know, there have been situations where we've initially done a discussion with, even with me, at the side of the difficulty of saying that you're a healthcare worker. You get knocked down the system. They go, oh, it's fine, there's someone's looking after them. And you've got, what, a big pen, and that's it. So, yeah, you have to go with what's in front of you, but if there's a genuine concern, then you go back on and talk it through, and the call handler will deal with it. You just don't know what they're managing at the other side. Yeah, but good point.
One more question. Sorry.
Just a question about sleep. So learners often ask this, you know, we used to say don't let somebody sleep initially after a concussion, and we're saying yes, get them to sleep. If they want to sleep, let them sleep. Would you be trying to just check awareness every so often, things like that? What's your view?
I would, well, obviously if there's a changing level of consciousness, you want to make sure that they are still rousable. Mm-hmm. So if they do, if you're in a nice warm tent and it's freezing outside and they've had a knock, there's a good chance that they will probably, and you've wrapped them up in space blankets, they'll probably want to have a bit of a snooze. I would just do that cruel, and I'm sorry if there's any nurses here, that cruel nursey bit, and poke them every 15 minutes, just so you get a response. You need to satisfy yourself, because the last thing you want to do is say, oh, I didn't check them for 45 minutes, and hold on, that's different. So part of your training will be regular observations. Sadly, if they're not rousable, that escalates it up, and then you start to poke it higher up. So yes, let them sleep, but within reason. Yeah.
Great. Really appreciate Niall coming on. He's got a fantastic wealth of knowledge, so please go chat to him at lunchtime.